Welcome back. This episode is about seemingly small ENT complaints that actually they're very high yield on the exam concept. Start with button battery ingestion. Danger is not just obstruction, it's caustic injury. When the battery is lodged in the esophagus, it creates an electric circuit with the moist mucosa. It generates hydroxide at the negative pole and causing liquefactive necrosis within hours. So on the imaging, you see that classic double ring or halo sign on EP film. If the battery is in the esophagus, this is an emergency. It must be removed immediately by endoscopy under direct visualization to prevent perforation or fistula formation. If the battery has already passed into the stomach in an otherwise asymptomatic child, it traverses the GI tract uneventfully and can be observed with serial exams and sometimes follow-up radiographs that contrast with your sharp foreign bodies, bones, toothpicks, needles, where even in the stomach, you're more aggressive because of perforation risk. So, more generally, foreign body ingestion management hinges on symptoms and object type. If the patient is entirely asymptomatic and the radiographs are negative, you can often observe. But if the patient has symptoms, adenophagia, drooling, chest pain, or a clear history of ingesting a sharp object, the safest move is urgent endoscopic removal to prevent esophageal perforation, mediastinitis, or tracheoesophageal fistula. Coins in the esophagus, large food boluses, and multiple magnets, they also warrant endoscopic evaluation rather than waiting it out. Batteries and sharp objects are they are never wait and see if they're still in the esophagus. So we have to do the endoscopy right away. From the esophagus, let's talk about your external area. Malignant or otitis externa is very high yield because missing it in real life is catastrophic as well. It's not just a simple swimmer's ear. It is an invasive infection of external auditory canal and skull base almost always due to Pseudomonas aeruginosa. The classic vignette is an elderly diabetic patient or someone immunocompromised with a severe persistent otalgia and purulent otorrhea. You do that otoscopic exam, it shows granulation tissue at the bony-cartilaginous junction of the canal, which is pathognomonic. Patients can develop cranial nerve palsy as the infection spread along the skull base. Typical topical drops are not enough here. Management is systemic antipseudomonal antibiotics such as IV or high dose oral Cipro or agents like piperacillin, tazobactam, or ceftazidime, and often we go for prolonged courses. In with simple otitis externa, when the patient is otherwise healthy, pain is very superficial, and topical therapy, topical Cipro is usually enough. In the inner ear, let's talk about vertigo. Meniere's disease is defined by the classic triad episodic vertigo, unilateral sensory neuro, hearing loss, and tinnitus, usually with a sense of oral fullness. So, what's the underlying problem here is there you have endolymphatic hydrops, increase in volume and pressure of endolymph in the inner ear. Attacks are usually spontaneous and they last from 20 minutes to several hours. And hearing may fluctuate early on but tends to progressively decline. The first line management they will ask is low salt diet and diuretics can be given. Vestibular suppressants like meclizine are used during the attacks. Um, BPP, BPPV is exactly the same name says, brief positional vertigo due to canalithiasis. This is calcium debris in the posterior semicircular canal. It is usually triggered by specific head movements, such as rolling over in bed or looking up. There is no hearing loss, and episodes last seconds, not hours. Usually, we do the Dix Helpic maneuver. It reproduces the vertigo and nystagmus, and treatment is purely mechanical. We do the canalith repositioning maneuvers like Eple, which guide the otoconia out of the posterior canal. Let's talk about snoring and obstructive sleep apnea because both involve upper airway anatomy and function. So, simple habitual snoring is incredibly common. Many middle-aged adults snore without apneas or daytime sleepiness. But OSA is characterized by recurrent episodes of the airway collapse during sleep, leading to intermittent hypoxemia, hypercapnia, and repeated arousals. Usually, patients have loud snoring. They have they have been witnessed by apneas and no non-refreshing sleep with daytime fatigue. The most common risk factor include obesity, craniofacial abnormalities, and use of alcohol or sedative hypnotics before bed, which actually further relax the pharyngeal dilator muscles and worsen the airway collapse. So, in a patient who snores but has no witnessed apneas, no daytime sleepiness, you start with lifestyle like weight loss, stop smoking, avoid alcohol, and positional changes. So, if there is a suspicion of OSA with daytime sleepiness, resistant hypertension, arrhythmias, you confirm with polysomnography, and treatment is CPAP along with weight loss. Um, Recurrent sinusitis is another ENT issue. It appears in both pediatrics and adult questions. Recurrent sinusitis means multiple discrete episodes of acute bacterial sinusitis with resolution in between, whereas chronic rhinosinusitis involves persistent symptoms of 12 weeks or more with mucosal thickening and remodeling. So anything that impairs mucociliary clearance predisposes to sinusitis, like for say ciliary dyskinesia, like Cartagena syndrome, and vasculitides, such as granulomatosis with polyangiitis. They actually cause inflammation and damage. So in recurrent sinusitis, you should think about underlying allergy actually. Hearing loss in older adults, presbycusis. This is symptomatic progressive sensory neural hearing loss due to degenerative changes in the cochlea and auditory pathways with age. High frequencies are lost first, so patients complain that they cannot hear high-pitched voices or that conversation is particularly difficult in noisy environments like restaurants. Where discrimination is impaired because of both peripheral and central processing changes. An exam relevant point here is that presbycusis is a major cause of social withdrawal, isolation, and apparent cognitive decline too. It can be misinterpreted as dementia or depression if you don't think about hearing. So management is primarily with hearing aids and environmental adaptations, and screening for hair loss should be part of geriatric care, right? So these are all the small vignettes they can test you in the exam.